Hi, good morning, everyone. My name is Mohammed Ibrahim. I'm one of the new physicians started here. I think many of you know me by now. I'm a consultant allergy and immunology and a consultant pediatrician. And it's my pleasure today to give the grand rounds. Today, I'm going to talk about atopic dermatitis, which is also known as eczema to many of you. I'm sure it's a disease that you've seen in your clinic one way or another at one point of your medical career. It's a very common disease. But today, I'm going to try and kind of tackle it from a different perspective, from an immunology point of view, focusing and highlighting the different red flags that you need to keep in mind when seeing some of these patients, because the eczema might just be a symptom rather than the primary disease. So let's get started. There you go. Okay. First of all, I have no financial disclosures or conflict of interest in the presented material today. And I'd like to start off with a case study. A 19-year-old, this is an actual case that was actually described in literature. A 19-year-old female with a past medical history of atopic dermatitis was referred to the allergy immunology clinic. She had severe eczema and food allergies, so she was merely referred for her atopy. But on further review, because us immunologists, we also like to ask about questions, we found out that she had recurrent acute otitis media when she was a child that required a tympanostomy tube, a grommet, which is something common we see a lot in histories of patients. She also had a lot of warts in her hands and legs that come and go. And she also develops oral ulcers that were swabbed previously, and they were mainly HSV1 positive herpes. On further history, she also had recurrent pneumonias. The CT scan of the chest that was done by physicians was normal, and it didn't show any nematoceles or bronchiectasis. Interestingly, on her family history, she had a brother who had similar symptoms and developed eventually Burkitt's lymphoma and required and passed away after a stem cell transplant. So this is the history that came to the clinic. The physicians then decided to start a workup. General CBC showed lymphopenia and eosinophilia, which is something that we can see with patients with atopy, especially eosinophilia. IgE was fluctuating, multiple levels were taken, and the maximum was 621. Immunoglobulins were sent and lymphocyte subsets because of her recurrent infections. And IgG and IgA were normal, but IgM was low at 35. Lymphocyte subsets, all types of lymphocytes, the B cells, which are the CD20 cells, the CD3 and CD4, which are different types of T cells, are all low. So at that point, because of her history, they decided to go ahead and do some genetic testing. And interestingly, on genetic testing, they found two heterozygous mutations. Both of them involving the DOCK8. So this is a compound heterozygous disease. One of the mutations involved DOCK8 was actually a deletion, and the other one was a splice site mutation. Because this was a new mutation, they actually sent functional testing to look for DOCK8 protein, which we will describe shortly in the presentation. And they found out that DOCK8 protein was low. So this patient was diagnosed with DOCK8 deficiency, also known as autosomal recessive Hyper-IgE syndrome. So the patient underwent hematopoietic stem cell transplant, and she was cured from all her symptoms. So this is just basically a case that shows a lot of red flags in a patient with eczema. You might not be so lucky in clinical practice to find this many red flags, but it's very important to keep an eye on them. So today I'm going to go over these. And again, they kind of highlight how eczema can be a symptom rather than a disease. And inborn error of immunity and primary immune deficiencies can masquerade as a patient who presents to you with severe eczema or eczema not responding to treatment and requires further workup. So let's talk first about eczema or atopic dermatitis in general. As many of you know, this is a chronic inflammatory skin disease. Prevalences of the disease in children especially has been up to 20%. It depends on the population. Some populations, it can be as low as 9%, some of them up to 20%. Adults, about 10% of adults can get atopic dermatitis in one form or another. When we talk about the pathogenesis of the disease, which we're going to discuss further, in the next slides, we're talking about two main issues with atopic dermatitis. It's a barrier dysfunction and it's an immune dysregulation. So those two combined will give you what we call eczema. Many of the patients with atopic dermatitis will present with a positive family history, but not all. And many of them develop secondary skin infections and can have elevated IgE and eosinophilia. So At this point, as you can see, skin infections are very common in eczema. So this is where the red flags can interchange. So sometimes you can have a lot of infections with patients with eczema, but they're usually more targeted toward the skin. If you see infections beyond the skin, that's when you start thinking of primary immune deficiencies. Elevated IgE and eosinophilia, as you will see, is seen not only in patients with hyper-IgE syndrome, but also in patients with eczema. So a patient with regular eczema, run-of-the-mill eczema, can still have elevated IgE levels. This is going back a little bit, 200 years in the past. And this is how important eczema is. It's actually been described from the year 1796. And this is a really nice historical drawings that I really like. On this side, you can, it was, at that point, they didn't call it eczema, they called it Strophilis convertus. And you can see the classic distribution of eczema regions, which are seen in children that are very young, over the face, over the extensor surfaces. On the other hand, this is 100 years after, almost, in the year 1835, and you can see what is called eczema ruborum at that point, and the distribution is at the flexure and the antecubital fossas of the child. So this is how old eczema has been in literature, medical literature, and even in historical drawings. Going forward 200 years now into the future, we see this is a nice image kind of summarizing the different genetics that have been identified over the years in association with eczema. The ones in the center are the most commonly associated, but as you go up and more, you will see more and more diseases are implicated. We will discuss some of them, things like flegerin, SPINK5, the different interleukins. These are all part of the eczema pathogenesis, and identifying these genes had helped us recognize patients at higher risk. And also, some of these genes and cytokines are targets for therapy. So we have indeed advanced so much in the management and diagnosis of patients with atopic dermatitis. So a little bit about the pathogenesis. This is a very loaded slide, but I'm going to try to break it down. I think it's very important to understand. I'm going to start off on your left side over here. So as we all know, the skin has multiple layers. On the upper part of the layer, the stratum corneum and the stratum granulosum, we have so many filaments and molecules that are important to keep our epidermal cells attached to each other. One of the most common ones is flegerin, which is a microfilament that attach different epidermal and keratinocytes together. When you have issues with flegerin, FLG, this is the mutation that we discussed before, or other genetics, as you can see here, and sometimes even deeper when you have issues with claudin, which is a tight junction gene, you will have issues with your barrier. So again, eczema is a barrier dysfunction rather than just an allergic disease. So there is an issue with the barrier, which will allow hydration to go out. So patients will always have dry skin. That's why they always complain of dry skin. But not only that, it won't only allow the hydration not to be maintained and go out, but will also allow irritant, pollutants, allergens, and microbes to actually go in. So it's not just allergens, multiple things can go in. So what happens when they go into our body? They causes an immune response. So this is where the second part of eczema comes in, which is the immune dysfunction. So in patients with eczema, they tend to release what we call alarmins, which is not done for all of us. Some of us will do. Alarmins include specific type of cytokines that alarm the immune system and induce the activation of the immune system. One of the major ones is TSLP, which is known as thymic stromal lymphopoietin. This, along with interleukin 25, interleukin 33, will cause the activation of immune cells, most importantly, mast cells, dendritic cells, and even lymphocytes. So here we will move to the second part. So when you come to this image here, you will see that TSLP, the alarmin we were talking about, will cause the activation and shifting of specifically T helper 2 cells. So as we know, we have T cells, B cells. Within T cells, we have multiple subtypes. We have T helper 1, T helper 2, T helper 3, and so on. T helper 2 cells are the ones involved in the pathogenesis of eczema. And when you have a lot of activation of T helper 2 cells, you will have a release of these specific cytokines. And these cytokines cause further damage to the tissue, cause activation and release of IgE, and cause itching even. So it's very important in here to see a couple of things I want to highlight. First of all, the interleukins, IL-4, IL-13, IL-31. Identifying those helped us in treatment of eczema. So a lot of the biologics that are used now and that can almost make your patients completely asymptomatic actually targets these interleukins and thus stop the pathogenesis of the disease. Number two that I want to highlight is that the itch cycle in patients with eczema is not really histamine mediated, but rather neurological mediated. So these cytokines, especially IL-31, causes the activation of your neurons and induce itching. So using antihistamine is just a supportive measure in patients with eczema to help them sleep rather than to stop their itch. If you want to stop their itch, you'll probably need other kind of medication that block these cytokines or block the alarmins and so forth. The other thing I want to highlight is the release of IgE. So we mentioned earlier that patients with regular eczema will have elevations in the levels of IgE, and the elevations can be actually so high, up to even 30. So the normal level is about 30 to 100. Patients with eczema can have up to 13,000 international units of IgE. And this can make it problematic in two levels. First of all, it might confuse you with some of the primary immune deficiencies. And two, it makes allergy testing very difficult. You know, in allergy testing, we check for IgEs of foods, of environment, and so forth. But when you have a total IgE that is elevated, everything will be up. So a very important point I want to notice is when you have a patient with eczema, and you're not suspecting history-wise that there is a food triggering it, it's really unnecessary to send food panels or IgE panels, because what will happen, you'll end up with having a lot of high levels that are not really useful in your management or more useful in the treatment, and just confuses the patient and confuses the physician and so on. So these are the major points I wanted to note. Also, just you can see here that the different cells profile change from acute to chronic and with continuous itch. And this is more useful for us to try to identify the stage at when the patient is at in their eczema. So now we're going to talk about clinically. How do these patients present? The majority of regular atopic dermatitis or eczema would present by the age of 2 to 3 months. And the distribution is like we described in the picture earlier. It will start off, especially in the younger children, over the face and over the extensor surfaces. And as they go into the school, it will switch to affect the flexural area. So inside the arms, behind the knees, and so forth. The diagnosis of eczema is clinical, purely clinical. You can do some of these cytokine testing and skin biopsies and so forth, but they're not very accurate. It's mainly clinical, and it's actually, because it's such a prevalent disease, it's not cost effective to biopsy every person you suspect of eczema. So we have this very good clinical criteria that involves both major and minor criteria. Patients with eczema will always have itching. They will always have a chronic relapsing dermatitis. So if it's itching with a chronic relapsing dermatitis, it is probably eczema. And then the other things that are supportive in the major criteria is early age of onset, typical regions that we just described, and a family history or past medical history of atopy. So not just eczema, asthma, allergic rhinitis, they all come together. This is what we call the allergic march. So we see them always clump in together. The minor criteria are specific skin manifestations and susceptibility to cutaneous skin infections. I will show you photos of these manifestations in a bit. So again, recurrent infections in patients of eczema are seen, and they're mainly skin. They include staph infections, eczema herpeticum, and even pityriasis alba, which is a fungal infection. And the reason why they have this is the barrier dysfunction. So again, it's open, the microbes can easily go in. Also, the itch cycle can contribute to it, because in patients who are itching, they're introducing microbes into the skin. And recent studies have shown that these patients, not only that, but they actually have some degree of immune issue where the antimicrobial peptides that are protective and found in the skin are not really that effective in these patients. So that's why they might be also at an increased susceptibility of skin infections. So these are some examples of the different manifestations or the minor criteria of eczema. This is xerosis cutis, which is basically dry skin, and you can see the crackliness and the dryness of the skin. This is white dermatographism, which is almost like when you stroke the arms or the legs of the patient, it will keep and leave a sign over there that would last for a few minutes to an hour. This is pityriasis alba, which is very, very common, and parents come for it because it's cosmetically disturbing. And it's a very common and benign manifestation of eczema that can occur, and usually requires no treatment. If it's really severe and disturbing the patients, you can use a low topical corticosteroids like Alphacort and so forth. And on the right here, this is empetygization, which is impetigo infection, a staph infection on an area that has eczema. And you can notice the yellow discoloration and the crusting that is common in patients with impetigo. So now to the fun part, the immunological diseases or the primary immune deficiencies that can present or come as symptoms of eczema. The most common one that can present or with a symptom that is similar to atopic dermatitis is Hyper-IgE syndrome. There are two major classes of Hyper-IgE, autosomal dominant and autosomal recessive. Autosomal dominant Hyper-IgE syndrome HIES means hyper-IgE syndrome. It's also known as Job syndrome. I'm sure you guys heard of this term before. Job, as many of you know, in Arabic, it's Ayub. This is the Abrahamic prophet described in the Quran and the Bible that was plagued with boils. So this is where the name came from. Patients with Job syndrome have a lot of boils, a lot of abscesses. It was described early on from a long time ago. And the main issue with these patients that they have a STAT3 loss of function. So what is STAT3? It's a transducer that is connected to many cytokines. So we know we have cytokines, we have cytokine receptors that are all over our bodies, and many of the cytokine receptors connect to what we call a STAT3. This is a single transducer that actually moves to the nucleus and causes nucleus activation. So when you have a loss of function of STAT3, you're at a higher risk of hyper-IgE syndrome. It's autosomal dominant hyper-IgE syndrome. I will not go into so much details into the pathogenesis, but here C, D, C, the other areas are another points of the interleukin-6 and the cytokine pathway that can be damaged and lead to autosomal dominant hyper-IgE. So when we talk about autosomal dominant hyper-IgE, we're not just talking about job anymore. We've identified so many other diseases involving these different components and these different receptors. So how do they present? Cold abscesses, boils, like we said, job. They also have a higher risk of fungal infections, pneumonias, and specifically nematoceles. That's why in the case earlier that we discussed, we said that the patient didn't have nematocele because that is a very big cardinal sign for patients with Job syndrome. They can have connective tissue and bone abnormalities, including specific facial dysmorphia. This is a typical faces of a patient with Job. You will notice that they will have prominent wide lips, wide nasal bridge, and they will have asymmetry of the face and prominence of the jaw as well. Another major feature that we always ask our primary immunodeficiency patients, and that can be very subtle and miss, is primary teeth retention. So some patients will have multiple rows of their teeth, and this can be described in these patients. Later on, when they grow up, a lot of them develop cardiac complications, including coronary artery aneurysm. So what about the other entity, autosomal recessive hyper-IgE syndrome? This is DOC8 that we described in our case. So DOC8 is actually an actin cytoskeleton rearrangement protein that is important to maintaining the shape of cells. So when you have a deficiency in DOC8, your natural killer and T cells will shatter. This is what we call cytothripsis or cell shattering. So when these cells shatter, especially in the skin, they won't be able to find infections. So a lot of patients with DOC will have a lot of viral infections, especially warts. If you remember, we go back to our case, she had a lot of warts that developed. So if you see a patient with recurrent warts and eczema, that's something to think of. DOC8 deficiency, specifically autosomal recessive hyper-IgE. They also tend to have very severe allergic disease. Another important entity with hyper-IgE is PGM3 mutations. These patients usually present with very severe neurological symptoms, poor myelination, poor development. So they're usually detected early on, seizures and so forth. So this kind of summarizes the two major types of hyper-IgEs, autosomal dominant and autosomal recessive, like we said. Autosomal dominant, also known as Job syndrome. This is the big red flags to think about. If you see a patient with nematocele, if you have a patient with facial dysmorphia, while patient with autosomal recessive hyper-IgE syndrome, mainly viral infection, warts, sometimes CNS vasculitis, food allergies, malignancies, and so forth. If you remember, our patient brother, who also had DOC8 deficiency and passed away, had Burkitt's lymphoma. So that's another thing. They can develop malignancies. This describes the different genes that are involved in autosomal dominant and autosomal recessive disease, and these are the laboratory findings that we usually follow up in allergy and immunology clinic. So what other inborn errors of immunity? This table kind of summarizes all of the other major inborn error immunities that can present with eczema. I'm going to go in detail in the next slide, but the one I want to point out to, because I'm not going to spend a lot of time on, is Wiskett-Aldrich syndrome, which I'm sure is probably the one that the majority of you heard of from this list. This is a triad that we've been taught a long time, even in med school, of eczema, combined immune deficiency, and thrombocytopenia. So if you have a patient with eczema who has recurrent purpura, petechia, thrombocytopenia, this is something to think about. And when you specifically look under the microscope, you will notice that these cells are not only less, but they're also smaller. So they have thrombocytopenia as well. So what about the rest of the list? IPEX, Omen, DiGeorge syndrome. These are different diseases that can present with eczema. Let's start with IPEX. IPEX is an acronym for immune dysregulation, polyendocrinopathy, X-linked disease. So these patients usually present with enteropathy, a lot of IBDs, a lot of diarrhea, a lot of thyroid disease, diabetes, as well. They tend to be boys. It's X-linked disease. And the damage is in FOXP3 gene. The FOXP3 is found in T regulatory cells. Some of you might remember that T regulatory cells, as the name suggests, regulate your immune system. So if you have an overactive immune system, this is supposed to calm it down. So if you have a damage with a disease that calms down your immune system will be overactive. And that's why they have all these autoimmune manifestations in this immune dysregulation. That's why they have this endocrinopathy disease. They have thyroiditis, they have diabetes, because they have a lot of autoimmunities. And they tend to have a lot of IBD-like features as well. The other two conditions, which are usually presented at very young age, so these patients will be very, very young, usually in the first few months of life, are Omen syndrome and DiGeorge syndrome. They present with very severe infections, life-threatening. They'll be admitted in the hospital at a very early age with sepsis, disseminated candidiasis, and the skin lesion to look for are eczema and erythroderma. I'll show you a couple of photos of erythroderma in a bit, but they'll basically have a flare-up of all over their skin, very red, very itchy, and they'll have very severe infections, like we said. An important one is Comell-Netherton syndrome. I left it in its own slide because this is a major differential for patients with eczema, and it can present at any age, even a little bit older. It can be missed. I actually had an adult patient that was diagnosed with Comell-Netherton. So this is how subtle the presentation can be. Some of them can have severe skin manifestation immunodeficiency, some of them a little bit of immunodeficiency, and mainly they will have issues with their hair and issues with their skin. So in Comell-Netherton, the issue is with the SPINK5. This is a gene that is important for the formation of a protease inhibitor called LEKT1. So if you have an issue with your protease inhibitor, so you won't be able to inhibit the proteases, your protease will be overactive, and this overactive protease will break down your skin, and thus you will have the dry skin and the eczema-like features. Another important pathognomonic sign is trichohexis invaginata. So if you suspect Netherton, and you don't have access to genetic diseases, you actually can take a hair sample and examine it under the microscope. And you will notice this characteristic bamboo hair. You'll see these little beads over here in the hair. This is what it's kind of pathognomonic for this disease and helps you diagnosing it. Another one is SAM syndrome. This is an acronym for S, severe dermatitis, A, multiple allergies, and M, metabolic wasting. The characteristic sign is palmoplantar keratoderma. So their hands will be involved. They will have severe dermatitis in their hands, and it will be more yellowish, orangish discoloration in there. Very striking. So now, after we discuss the different diseases, we're gonna discuss how can you, like you're not supposed to memorize all the diseases or know them, but there are some red flags that can help you identify, oh, this patient might need the referral, oh, this patient might need further workup, I need to send genetic testing for him, and so forth. So let's talk about the different presentation. If you have a patient who present to you with eczematous lesions before the age, specifically age of 2 months, that is a big red flag. You're not supposed to have eczema before the age of 2 months. Some of them might have a very mild disease, but if you have eczema in general before that age, it might indicate an inborn error of immunity. Remember that some of the severe immune deficiencies like Omen and IPEX can present very early on in the first few weeks in life. If you have a patient who presents not only with eczema, but generalized inflamed skin, so erythroderma, think of IPEX and Omen. If you have a patient who has petechia and purpura, think of Wiskott-Aldrich. And if you have ichthyosis, think of Netherton, SAM syndrome, and DOC8. So how do these skin lesions look like? First of all, ichthyosis, you will not be able to miss ichthyosis. It's severe dry skin. So remember the xerosis I showed you earlier, it was very mild in comparison to this. You can see this is almost like alligator skin, very much scaly. And this severe dryness of the skin is what we call ichthyosis, and it will need an immunological evaluation if you see this. Erythroderma, so generalized redness of the skin, you can see here in this little baby. This baby actually was diagnosed with Netherton syndrome because not only did he have this, but you can notice some scaling over the face, around the mouth. So when they did genetics, they found out that he has Netherton. And finally, this is the small petechia along with the eczema. The eczema is kind of subtle. You can see it around the neck, on the chest, but you see the small little dots all over. These are petechia, and it's indicative of possible thrombocytopenia and possibly Wiskott-Aldrich. Another red flags to look for are oral thrush. A lot of babies have oral thrush. That is understandable. But when you have an oral thrush that is not resolving with your typical nystatin drops, that is persistent or extensive, like going down to the esophagus, or you see it extensively over the diaper area, not resolving, this is when you think of an immune deficiency and an issue with your T cells and possibly Job syndrome. When you have recurrent viral infections beyond the typical eczema infection. So again, with typical eczema, you can have local herpes, local staph, but you have things like warts or molluscum, then we start thinking of things like DOCK8 deficiency and autosomal recessive hyper-IgE. Bacterial infections, we discussed this. Staph is fine, very common in patients with eczema, but severe staph that leads to sepsis or cold abscesses, like we said, boils, that's when you, or extracutaneous infections like pneumonias, nematoceles, that's when you start thinking of immune deficiency, things like staph3 hyper-IgE. CNS involvement, multiple of them. If you see CNS with eczema, it's good to further evaluate. If you have recurrent diarrhea or chronic diarrhea, again, IPEX, omen, and so forth. Food allergy and anaphylaxis is a little bit tricky because up to 40–50% with patients with eczema will have some degree of other atopy. But if that food allergy and anaphylaxis is severe, if it's life-threatening anaphylaxis all the time, we start thinking beyond that, things like inborn errors of immunity. So again, other things to keep in mind: connective tissue disease, autoimmune disease, bone disease, dental abnormalities like retention of primary teeth are all indicative of red flags that you need to keep an eye on. So what kind of workup do we do for these patients? You guys can start the workup actually by sending a CBC, which is simply done. You'll notice maybe lymphopenia. So if you have your eczema patients, you're suspecting, and you have a persistent lymphopenia, then there is an issue. Thrombocytopenia, like we were mentioning before, seen in Wiskott-Aldrich and IPEX. Eosinophilia, I wanted to touch on this because it's a lot of concern to patients and to physicians when they say eosinophilia in patients with atopy. And it is rightfully so, because eosinophilia is not something normal. However, it is seen in regular atopic dermatitis. You can see numbers up to 1,000, 5,000, and even beyond that. But that doesn't mean that they don't need a workup. Anytime you have an eosinophilia more than 1,500, that's the key number, that's a reason for workup. Whether it's a parasitic workup, whether it's an immunological workup, they need some degree. We will decide the extent, whether they need genetics, whether they need bone marrow or not, but a workup needed for anyone with the eosinophilia of more than 1,500, although it can be normally seen in patients with eczema, but it is worth a workup. Lymphocyte subset, this is some specialty testing and immunoglobulin testing that we do in the allergy immunology clinic, and of course, genetic testing for these patients to finally pinpoint their immunity issue and provide treatment and management. So this is kind of a summary of what we're talking about. Initial red flags, basic laboratory workup that has some red flags, and then referral to an immunology for a workup. I'm just going to spend a minute going over the red flags again. Extensive onset of eczema before 2 months, oral candidiasis persisting beyond treatment, disseminated viral infections like herpes, Coxsackie, or severe molluscum or warts, generalized ecthyoform skin, so this alligator skin, chronic or recurrent diarrhea, endocrinopathy of multiple endocrine organ at a young age, connective tissue disease, facial or hair abnormalities, purpura, and petechia. So these are some of your red flags of inborn error of immunities. Some of the red flag lab work: elevated serum IgE. Again, it can be normal, but it can be part of immunity. So it's worth a workup and further history and physical exam. A blood smear showing abnormalities in lymphocyte size or thrombocyte size, immunoglobulin levels that are low, specifically IgM, IgG, and IgA, and low vaccine titers are also indicative of possible inborn error of immunity. Finally, the management and treatment of these patients. Because eczema is a symptom, it still needs to be treated. Topical steroids and anti-inflammatory are useful for many of these patients. Sometimes we use even topical tacrolimus, topical pimecrolimus, and so forth. Patients that have very severe eczema might require biologics, like we were mentioning earlier, anti-IL-4, anti-IL-13. So dupilumab is the big biologic that changed the management of a lot of patients. Very useful. And it's actually not only useful in regular eczema, but also have been found to be useful in patients with Job syndrome. There are case studies of using it in patients with Job and patients with SAM syndrome. Secukinumab is an anti-IL-17 that also is useful in patients with Job syndrome and help a lot with the underlying pathogenesis of these patients. This is the general eczema treatment. Some mutations might also benefit from JAK inhibitors. These are the new players in the block, the new medication, and they're very useful in patients with Netherton syndrome, for example. Now, there are specific treatments for the inborn errors of immunity, and that's why it's important to pick up these red flags, because it will alter the management. Like we saw in the case at the beginning, hematopoietic stem cell transplant can be life-saving in these patients. You're not just aiming to treat their eczema and their itchiness, but their underlying immune deficiency and underlying infections, reduce their morbidity and mortality, and so forth. Some of the patients with Job syndrome will require long-term antibiotics, antifungal. They might even require IVIG, intravenous immunoglobulins, and so forth. Patients with DGeorge will require thymic transplant. So different diseases will have different managements. And that's it. Those are my references. And thank you very much.